Hello and welcome. I'm Adam Thompson from Paramedicine101.com, and this is the ECG interpretation and case review for ECG case number 8 from the Paramedicine 101 Facebook site. Here's the case that I gave. You respond to a residence. It's a 24-year-old male. He looks like he's having some anxiety. He even tells you that he feels anxious and he's kind of hyperventilating. We've all seen this type of patient before. It's an easy, slam dunk case. You just get them to slow down their breathing, and then everything else kind of falls into place. It's, symptoms will subside. So he tells you he's short of breath and he's got paresthesia. If you don't know what that means, it's just, numbness, tingling to your hands, kind of the pins and needles feeling that we see a lot with hyperventilation. You tell your patients, that's from the breathing. You need to slow your breathing down. You speak to them very calmly, and you can usually kind of help these patients. This is usually something that's not going to harm them too much. If they hyperventilate too much, they'll end up passing out. Their breathing rate will slow down. They'll wake up and hopefully be breathing just fine. And we've all seen the old paper bag technique used because we know that they're blowing off too much CO2. I don't advocate using a paper bag or a non-rebreather with oxygen not flowing. It doesn't look very good. It doesn't look professional, and you might not be treating the right thing. So the patient also tells you that he doesn't have any allergies. He takes Adderall, and on the Facebook site we had a lot of comments about Adderall producing ST elevation or ST changes, and things to that effect. But I updated the site and said that his pill bottle looks to contain the correct amount of Adderall pills. He doesn't look like he's been abusing the Adderall pills. But I did throw that in there as kind of a curveball. ADHD and depression, just like every 24-year-old male these days. He tells you he just had a sandwich an hour ago. That should not really make you think anything of this case. Says he was studying for college finals. We know sometimes college students might take drugs or stimulants or maybe too much of their Adderall to help them study for finals. But it doesn't look like he's been taking any drugs, or you don't have any suspicious belief that he has been. Respiratory rate, 40 breaths per minute. Okay, that's hyperventilation. Heart rate of 115, a little tachycardic. Blood pressure, a little high for a 24-year-old. O2 sat, 100%. Okay, skin pink, warm, and dry. O2 sat's very important because that kind of rules out the hypoxic causes for tachypnea. Somebody else asked for end-tidal CO2 on the site, which I thought was very good because we know that these patients blow off too much CO2 and their end-tidal CO2 will be lower. So I gave a CO2 of 30, which isn't too low, but it's lower than normal. So we're a little concerned. We try to calm this patient down, get an EKG, and determine any other possible causes. For the most part, this all kind of fits, hyperventilation syndrome, anxiety. Hopefully we can just get this patient calmed down and their symptoms will subside. But we have to have an EKG, or otherwise this would be boring. So we take an EKG, and here's what we got. I got all kinds of feedback on this EKG. Anything from acute myocardial infarction. Some people thought hyperkalemia. Some people thought, early repolarization. I got all kinds of stuff. So I'm going to give my interpretation of the EKG based on the most probable stuff here. So first off, let's take a look at it. What's our rhythm? Our rhythm doesn't fit the heart rate that I just gave you. That should be the first thing you notice. This is not a heart rate of 115. So let's hope that we slowed down the patient's heart rate by calming him a little bit. And now we're somewhere maybe in the 80s. So we have P waves, and they are upright for the most part where they need to be, and negative and AVR. So we could probably call this a sinus rhythm. And we have upright QRS complexes in leads 1 through 3. Okay, all of the QRS complexes are upright. That tells you right off the bat you have a normal QRS axis. That's a quick and easy way of telling. And continuing on, we look for any other changes, T-wave changes, ST changes. I do see the ST elevation that everybody else sees, hopefully. We see ST elevation first over here in the inferior leads, just kind of underlining the leads that have the ST elevation. See maybe what looks like a biphasic T wave in V1. I'm going to talk about that a little bit more. and we see maybe slightly inverted T waves in AVL. That should concern you, of course. When you see something like this in AVL, you should be concerned for an inferior wall MI. I've talked about this before. There is no ST depression, though. Okay, it might look like it at first, but I want you to kind of just draw a line from the TP segment backwards to measure your ST segment or your J point, and you'll see that it is not elevated. I don't want to get ahead of myself here, though. So continuing on, we do see Q waves. Okay, Q waves we know are can be a sign of infarction. So we're going to talk about those too. But I want to give you this list here. It's kind of my differential for ST elevation, and it's easy to remember because it spells out elevation. Okay, so the first thing on there is electrolytes. I did have a few people say hyperkalemia. Hyperkalemia was a thought for people, and it does cause ST elevation. Hyperkalemia, Dr. Amomatu calls it the syphilis of electrocardiography. It's the great imitator. Okay, so we need to consider that when we see ST elevation or ST changes. And I think the reason that some people thought maybe hyperkalemia was these T waves that look, maybe peaked to some people or tall or hyperacute-ish. These T waves, they're a little bit wide, okay, for hyperkalemia. They're not very symmetrical. You notice that they come up, it takes a little bit longer to come up to the peak than it does to come down, okay? So these are more physiological in appearance. They're not hyperacute looking or hyperkalemic looking. Their height is proportionate to the height or the length of the QRS complex, if you will, which is normal. Normally, your repolarization is proportionate to your depolarization. So that's kind of normal. And this patient's having hyperventilation. They don't have any renal disease. Hyperventilation syndrome, if anything, will lower your serum potassium level. It will not increase your serum potassium level. So we're not thinking hyperkalemia here, okay? Moving along. Hyperkalemia, gone. All right, moving along. Let's use a different color. Left bundle branch block. Left bundle branch block. All right, let's take a look at it and consider it, because you have to consider it with ST elevation. Do we have a wide QRS complex? No, we do not. We have a narrow QRS complex. And that kind of just knocks left bundle branch block right off the list. That was easy. Okay, we're going to skip early repolarization for now. And ventricular hypertrophy, LVH, is a common cause for ST elevation. So let's take a look. And for LVH, I like to look at the precordial leads most often. And they do look a little large. Okay, these QRS complexes look a little large. But remember, it's a 24-year-old male. That's normal to have large voltage or for a young male. So we're not really thinking so much a hypertrophy as just normal variant. Also, left ventricular hypertrophy, when you're looking for ST elevation, it causes something called a strain pattern, much like left bundle branch block does, which would give you a downsloping ST depression and T-wave inversion in these left precordial leads over here, V4 through V6, where you have upright T waves in all of these. So we're not really seeing that left ventricular strain pattern that LVH causes. So I'm going to knock that right off the list. Ventricular hypertrophy is gone. Okay, so A has two things here. It's got aneurysm and acute pericarditis. Aneurysm, I'm going to knock that off the list because a ventricular aneurysm is caused usually by somebody that's had a previous myocardial infarction, and it's very hard to differentiate on an EKG between a left ventricular aneurysm and an MI. I think pre-hospitally, you kind of got to err on the side of what does your patient look like with the EKG that goes along with it. So let's talk about acute pericarditis for a second, because a few people did mention acute pericarditis. Well, looking back at this EKG here, we do see ST elevation, and you can call this global ST elevation. You don't have to have it in every single lead. In fact, sometimes with acute pericarditis, you'll get ST depression in V1. This may look like acute pericarditis to you, but what does the patient look like? Remember, you have to consider the company the EKG keeps. This is something Tom Boothele talks about a lot, something he learned from Dr. Thomas Garcia, who was a EKG guru. And this EKG may look like acute pericarditis, but if your patient doesn't present with positional chest pain or a fever or anything that leads you to believe that they would have some sort of myocarditis or acute pericarditis, why would you think acute pericarditis? Well, let's look at the other things that some of you guys talked about. PR depression is not present, but remember, don't look for PR depression with acute pericarditis as one of your first things that you're looking for. What I mean by that is PR depression is only present usually with viral pericarditis. That's something I learned from Dr. Amomatu, and it might not be present with most cases of acute pericarditis. So that should not be something you're looking for initially. The ST elevation is concave up, okay, and you do have more ST elevation in lead 2 than in lead 3. That's something you should remember. With an MI, you almost always have more ST elevation in lead 3 than in lead 2 if you're looking for an inferior wall MI, okay? So you should remember that. So it does kind of correlate, the EKG kind of could look like acute pericarditis, but the patient doesn't. So we got to think of other things that might do that. So I'm going to circle acute pericarditis, not necessarily cross it out. I'm not really thinking it because the patient doesn't fit. Treatment, we can cross that out because we're not really doing a pericardiocentesis on this patient. Injury, that's your MI stuff, okay? Injury. We don't have any traumatic injury, so I'll cross out contusion. But AMI, all right? So let's think. Is there acute myocardial infarction? Well, like I said before, these T waves are not pathological in appearance to me because they're not symmetrical, okay? The ST elevation is in leads that do not correlate with each other, meaning you see some, although minimal, ST elevation in lead 1. And the reason it's important is because lead 1's entire QRS complex is small. So minimal ST elevation is important when you see a small QRS complex. And you should never see ST elevation in lead 1 with these leads below it, the inferior leads, because they're kind of reciprocal to each other. And knowing that, there's only a few instances where you'll see something like this, acute pericarditis, early repolarization, an apical infarct, which is very uncommon. So continuing on, all of the ST elevation we see is what we call concave. It's more of a benign appearance, okay? And the way that you're going to determine if ST elevation is concave is draw a straight line from the J point of the complex to the peak of the T wave. I did it over here in D5, okay? And if that ST segment falls below that line, it's concave. If it's above it, it's convex. Now, when ST elevation is convex, and let me see if I can draw it up here on top. When you have convex ST elevation like that, okay, that would be bad, okay? We call that like a tombstoning appearance. That is always pathological. Let's just say it's always pathological in our minds. When it's concave, let me see if I can draw it here. Like this, okay, and that kind of emphasized it there. When it's concave like that, it's usually not bad. It can be an infarct, but usually it's not. Now, a lot of the cases I show online are concave ST elevation, and a lot of them might be infarcts because we have to, those are the ones that become hard. When you see the tombstones, those are not difficult EKGs to interpret. That's pretty much a home run infarct every time. So we have to look at these ones with the concave ST elevation and really talk about these and learn some ways to differentiate them. Now, I just want to mention that I talked about this biphasic looking T wave in V1. The reason it looks biphasic, it is in some respect, but also right after it you have, that was a bad drawing there, you have a U wave. And you know it's the U wave because you see it in V2 and V3 as well. And that's going to be important, something to talk about here in a second. Also, V1, it's normal to have a biphasic T wave. It's normal to have a very small positive T wave, and it's normal to have a negative T wave. V1 will always have a low voltage T wave unless you're talking about an infarct. If you ever see a T wave that's bigger, more positive in V1 than in V6, you've got to think infarct. That's not the case here, though. So, acute MI, still a possibility, but it's very, very unlikely. The patient's young. He's otherwise seemingly healthy. He took Adderall, but he takes that normally, and he didn't take too much from what we can tell. He doesn't have any chest pain. He has shortness of breath, but it's presenting as hyperventilation. It's not so much dyspnea in the respect of like an angina equivalent is, where you get it with exertion and things like that. So it just doesn't really fit MI. It doesn't really fit pericarditis. Osborne waves, now that's with hypothermia, okay? He's not hypothermic. And non-occlusive vasospasm, that's your Prince-Meadows angina or your drug-induced infarction, like a cocaine-induced infarct. We don't have any reason to believe that he has this going on, okay? It could be possible that he's on drugs. It could be possible that he's having this situation, but we don't have any reason to believe that. I'm going to cross that one out, okay? So the one I haven't talked about, early repolarization. Let's take a look. Does early repolarization fit this? We do have all concave upward ST elevation. All right. We know that early repolarization is most commonly seen in these leads. I'd say V2 to V4 is the most common area you'll see early repolarization. And that we do see ST elevation in those leads. Less commonly, you'll see it in the inferior leads. Okay? But we have to look on. These Q waves, I should have talked about this when we were talking about infarct. These Q waves are not pathological in appearance. Okay? These Q waves that we see here, they're very narrow. Now, there is a condition you should be concerned about when you see narrow Q waves in the lateral leads. It's called hypertrophic obstructive cardiomyopathy. Let's just say that this patient doesn't have that right now. These Q waves, I talked to Dr. Amomatu about the Q waves on this particular EKG, and he said he doesn't concern himself too much with Q waves, when they don't have a pathological appearance or outside that high voltage hypertrophic obstructive cardiomyopathy appearance. So he said that it's just a benign Q wave. It's narrow, it's short. You shouldn't be too concerned about it. Okay. Looking further, early repolarization. Other possible indicators that this is early repol. We don't have any reciprocal changes. We have a lot of leads with ST elevation that not have any reciprocal changes anywhere, okay? Other things, he is young. Now, I don't want you to think benign early repolarization only occurs in the young. You can have elderly patients that have early repolarization. In fact, it's common. So don't just think, oh, it only happens in the young people. That's not true. So early repolarization is a possibility. What else do we see? Look at V4 and look at the J point in V4. That is your notched J point that you hear a lot about with early repolarization. Basically, you're having an early takeoff and it notches that J point. A little bit in V5 as well. Okay. And this is also called that fish hook ST segment. I don't know if you've read that before. And I've also seen in Tim Phelan's book, he does a smiley face with it. So you remember that this is the type of ST elevation that's not as bad as opposed to convex, which causes a sad face. All right, so hopefully that helps you remember it. So we do have a lot of indicators of early repolarization. Now I want to talk about Dr. Stephen Smith from Dr. Smith's ECG blog. If you haven't been on there, just Google it, Dr. Smith's ECG blog. It'll come right up. And he talks about early repol a lot. And he's got a formula that he uses to identify early repolarization. Basically, he takes the ST elevation found in V3. It's about 60 milliseconds after the J point. And he uses that along in a formula with the amplitude of V4, the R wave in V4, and the QTC interval. Okay, so what I'm going to talk about here, we don't see, these are the indicators that you would have an MI. If you have late R wave progression, that's more indicative of an anterior wall MI. We have very intact R wave progression here, okay? Looking at V1 to V6, we have a smooth transition and a very tall R wave in V4. That is less indicative of an MI. Also, the ST elevation in V3 is minimal, maybe 2 millimeters at the most. And just as a rule of thumb, before you call STEMI, if you see ST elevation in V2 and V3, and those are the leads you're looking at, if you don't see at least 2 millimeters of ST elevation, you really shouldn't be calling STEMI. Look for more indicators, unless, of course, you have reciprocal changes or something that really drives home STEMI, or if it's convex. Also, the QTC interval, I didn't give you the numeric printout on this EKG, but I did Bazette's formula and figured a QTC interval for this of about 436 milliseconds. 436 milliseconds. That's in the normal range, even closer to shorter. So we're not too concerned about a longer QT, which occurs with an anterior wall MI. We have intact R wave progression, which is a good sign that's less indicative of an anterior wall MI. Okay? And Bazette's formula, if you don't know it, you can Google it. It's just the QT interval over the square root of the R interval. Yeah, that's very confusing, I know. So I usually just go with whatever the printout is. Unfortunately, I didn't have it for this EKG. So everything kind of points to this early repolarization. All right, I went on Dr. Smith's ECG blog, and I plugged the numbers in, and it did kind of correlate with early repolarization. It was not indicative of an anterior wall MI. So what are the things that drive home early repol on this patient? Other than the fact that he's 24 years old, no reciprocal changes. That's a biggie. If you have reciprocal changes, it takes all the other STE mimic rules out, okay, and just drives home MI. Once you see reciprocal changes, you got to think MI. All right, R wave progression intact. That's another big one. If you're considering, well, is this an anterior wall MI or is this early repolarization? You got to look at R wave progression. And if the bigger the R wave and V4, the more likely it's not an MI. Prominent U waves. Okay, I didn't say anything about that, but let's look at this EKG again. Okay, prominent U waves are present here. Oh, wrong color to kind of see that. You see these U waves are present, very easily identifiable. I don't know why, but I know that Tom Bouthlet talked about it on EMS12lead.com, and it's something that Dr. Stephen Smith told him about. If you see prominent U waves on EKG, that kind of is more indicative of a benign early repolarization. Don't ask me why, because anything I tell you is kind of just me guessing. A shorter QTC interval, okay, we said was about 436. Notch J points, that's another big one. You'll see that with early repolarization a lot. Concave ST elevation, that's a big one. If you see convex, it's MI. If you see concave, it probably isn't MI. It still could be, but it probably isn't. History and presentation, another big one. You got to consider the company it keeps. There's nothing that indicates anything like acute pericarditis or myocardial infarction or drug-induced vasospasm with this patient. So, you will do subsequent 12 leads, of course, and you won't see any changes on those 12 leads either. Another reason to believe that this is early repol. Cover this stuff, go listen to this video again. Maybe there's some stuff you missed. You got to remember this because this is one of the harder STE mimics to kind of identify this versus anterior MI especially, because it's very common. Less commonly, you'll see the ST elevation over here in these inferior leads that you see here. But it can happen, and you got to just take everything into account. If you have any cool cases, or if you want to just ask me any questions, send an email over to paramedicine101@gmail.com, and I'd be glad to talk to you, maybe feature your case in an upcoming ECG case. This has gotten to be a very lengthy video, so I'm going to cut it short and just say, have a good, happy holidays, and I'll talk to you next time.